So, welcome everybody. I would like to introduce Dr. Nick Maguire. He's been a regular member of our network, but I will just formally introduce him. He's an associate professor within psychology at the University of Southampton. He qualified in 1999 as a clinical psychologist, completed his undergraduate degree there, but he's always combined his clinical with his academic roles. So he comes from a very informed position to present to us this morning. I'm going to hand over to you, Nick. Thank you for showing your slides. So over to you.
So we talk about formulation, and formulation being sort of understanding the relationship between past experience, current behaviour, and why problems are kind of maintained. So we often talk about the 3 Ps of formulation when we're working psychologically with somebody. So we talk about the predisposing factors. So what is it in somebody's history which means that there is an issue now, and what second P is what precipitated it. So why now? Why has the problem happened now? Which makes less sense when you're talking about sort of chronic issues such as homelessness. But arguably most important is the perpetuating one. Why is it still going on? What are the kind of behavioural and psychological cycles and the interrelationship between the two which mean that this problem isn't going to go away? Any questions, as Karen was saying, yeah, please do log in the chat, and we'll deal with those afterwards. I'm going to try and keep the chalk and talk for only about 20-25 minutes, giving enough time for us to discuss the issues. None of this is going to be new. Some of the emotion reasons kind of maybe people start using. Now, emotion regulation is a really big one. There's a lovely paper, a meta-analysis by Susan Aldoa and Susan Nolan-Huxamer, which I can put the reference in, which looks at the function of particularly self-harm and some across diagnoses, and emotion regulation is one of the key things, including with drug and alcohol. And we would argue that drug and alcohol serves the function of regulating emotions, and we'll look at why regulations need external, or emotions need external regulation in a minute. Cognitive suppression. So a lot of my clients, someone used to talk about drinking thinking, and they used to say, when particularly around PTSD, if your internal world, particularly the cognitive world around intrusive thoughts and very negative and distressing thoughts is difficult, then sometimes you can change. What he used to describe is it changes the quality. He says you don't not stop thinking about them, but it just kind of lessens. I think what he's saying is it lessens the emotional impact of thinking about those things. Social processes, obviously, particularly around the separation process. We're going to talk about attachment, which is early years, and then the separation process, which takes place in teenage years, when in our evolutionary past, kind of when kids hit puberty, they're supposed to be separating from the family and going establishing themselves, whereas of course we keep teenagers, which are proto-adults, as children for a lot longer, and they're desperately trying to get away from us, causing what I seem to view as a very particular type of personality disorder. Teenage years is massive emotion dysregulation, hormones all over the place, and some maybe challenging behaviours. And particularly identity things, establishing identity. And of course, what can happen is that a way of rebelling against parents and a way of forming your own gang outside of the family is to get engaged in common practices such as drug and alcohol use. Habit, structure of the day. Some of the guys that we work with, this is just what I do now. I go out, I steal and deal, and then I score, and that's the way my day goes, as a kind of a form of habit. And we've got, in terms of maintenance, avoidance of withdrawal symptoms, and a number of other things which we'll talk about in a bit more detail. So very quickly through sort of ACEs, adverse childhood experiences, and attachment. A biosocial model which underpins dialectical behaviour therapy is around early invalidating environments, combined with a genetic predisposition for high arousal. So there are kind of personality differences or just differences in our genetic makeup, which makes some of us just more prone to getting wound up than others. We describe people being phlegmatic or highly strung, or even as children. And there's some genetic and then behavioural genetic components to that, obviously, in terms of kind of like predispositions being turned on and off. So through by environmental contingencies. So there's something about the combination of this invalidating environment, and what we mean by that is very little attention being paid to internal experiences, and sometimes even naming internal experiences. So some of the people that we work with really struggle to name the difference between anger and anxiety, for instance. Two very different emotions, but they feel just like crap or more crap. It's very difficult because they haven't had an opportunity to rehearse what the difference is and what the label for that internal experience is. Together with, we did a lovely piece of research we've yet to publish on discriminating or facial expressions, particularly emotional facial expressions. And what we found is that the people within the homeless population that we had that were good enough to engage in our experiment really struggled way more than a non-clinical comparison group to distinguish the anxiety and anger in others. They really that was the particular one they struggled with. They struggled with generally kind of decoding facial expression of emotion, but that seems to be kind of the tricky one. And this is associated with early neglect and abuse. Safety in relationships that are not experienced, and people don't learn to soothe themselves. They don't learn the kind of, hopefully most of us have learned a kind of a narrative and an internal way of soothing, which may involve others, and it may involve a loved one or somebody very close to, and we just feel better sometimes when we're there. Sometimes, perhaps if we've had a bad day at work, we might go and do the very thing that to self-soothe, which is along the same kind of substance abuse continuum. We might have a glass of wine, or we might have another glass of wine, or eat chocolate, or ingest some substance which kind of makes us feel a bit better. So we can start to see where substance ingestion is functional and related to emotion and difficulties in and emotion regulation. So the adult sort of things that happen obviously in adult life after having had those difficult childhood experiences: difficulties in regulating emotions, difficulties in relationships, trust issues, particularly around anxious, the presentation of anxious attachment. We talk about avoidant attachment, anxious attachment, and disorganized. I won't go into the details of that, but particularly anxious attachment, where you crave that closeness, but it's a constant fear that people are going to be leaving you and you're unsafe, and it's the intensity of the emotions is beyond what most of us could even imagine. Behavioral inhibition, so people tend to be very impulsive, not think through consequences, and very negative beliefs about self, and particularly about the way that others might view us. So other people think I'm crap, and in fact I think I am as well. I'm inferior, I'm not worthy, I'm unlovable, I'm bad. These kind of very core beliefs tend to be very common. So thinking about kind of the barriers, we're going to be thinking about individual and structural or systemic barriers to recovery from drug use stuff. So we're not going to go too much into the individual therapy because that would take another 3 days. But if we just think on a very high level about barriers, so engagement in change is one of the biggest ones. If somebody has been engaged in a habitual behaviour for a long time, that behaviour is very, very hard to change. And we talk about MI has got a motivational interviewing has got a really nice language for kind of describing those difficulties in terms of change, which we'll talk about in a second. Understanding some very abstract concepts such as triggers. So we talk about cravings, and there's a sort of a physiological process, a homeostatic process, which can govern cravings particularly, and they tend to be classically conditioned. So if you walk past the end of the road where your dealer usually is, we might experience cravings because of a classic condition process that usually then you would be ingesting something. Emotion and cognition around internal, external triggers. This is a real tricky one. Now, the external triggers are easy to see. So it might be an argument, it might be a relationship breakup, it might be somebody shouting at you or being condescending, which generates emotional response. What's more difficult to see is the internal triggers. So a memory or a thought about something. And we often see some people apparently exploding out of nowhere. And what we then, if we investigate that with and sit down with the person, we'll find out that usually there's stuff that's happened during the day, which is So the kind of the emotion bucket has been filled up, and then it just takes a small thing to tip people over. And it might not have been an external trigger. It might be something that's gone on inside, some memory or rumination about something that happened in the past. Withdrawal, obviously, and avoidance of withdrawal, and then some social situational triggers, which might not be easy to see, but even walking into an environment where some people are, who maybe somebody who's had a beef with, or trickiness with, or owes money to, or whatever, they can be triggers. We talked a bit about habitual use, and the way in which those can structure a day, very hard to let go of. And then we've got some other stuff about beliefs about sleep. So I get, one of my, a number of my patients have talked a bit about, well, I drink because that's the only way I can sleep. But of course, they get into a very negative cycle of the quality of sleep being affected, which then means that they're tired, which then perpetuates that belief about needing to drink to sleep or take some other sedative. Managing chronic conditions, particularly pain. So people using cannabis a lot for pain, but also things like heroin for pain management or other kind of chronic physical health problems. So we've got this real complexity and these dynamic relationships and interrelated sort of trimorbidity, so physical and mental health problems, and we've also got rough sleeping, which starts to make the use of something very understandable and arguably a coping mechanism. So if I struggle to regulate my own emotions, if I struggle to calm myself down, and I'm in a situation where opportunities for anger, anxiety are very high, like a hostile situation or a situation where relationships are tricky, then it kind of makes sense. In order to change that very difficult internal state, it makes sense to ingest something. And I would challenge anybody to say that they've never done that. They've never done something external in order to try and manage an internal state. So we start to reconceptualize drug and alcohol use and self-harm behaviors as coping mechanisms. It makes sense to the individual given their emotional state at the time. Systemic barriers. So why is it that it's a real struggle to, particularly in terms of mental health services, to enable them to work with the people that we're serving? The separation of mental health and substance abuse in terms of diagnosis it's an inherently categorical process, and of course it's an inherent exclusive process, particularly so you see the two as differently. You diagnose them as entirely separate. You don't look at the functional relationship between the two, and of course then that leads to these beliefs, well, if they just stop using, then the mental health problems will go away, which I hear a lot, more than I should do. And the other big one is about current use making treatment more. There's no point to treating either in terms of pharmacotherapy or psychological therapy because it just won't be effective. So then that leads to well, just stop first, become totally abstinent first, or if you're really kind of forward thinking, maybe well, manage it better first before we will treat you. Now, of course, one of the things that might be underpinning this is very stretched NHS services and people trying to manage caseloads through exclusion of things which are complex and difficult, and we may not get results. So it may be that these are genuine thoughts, but it may also be that these are ways of managing caseloads. It's the belief that change takes place somewhere else. We will just refer them to somebody else for that to happen. Now, we'll deal with what we can do wherever people are in a second, or that we can do small bits and pieces. Hostel workers can work in a psychologically informed way to support people in terms of things like engaging and thinking about change, those kind of things. And then, of course, we've got the appointment systems and the way and the place in which change happens, the place in which treatment happens, which is not where our guys tend to be, and getting people to appointments at a particular time, particularly when people have other priorities, dealing and stealing and scoring, makes things very tricky. So there are a number of kind of structural barriers which we know about. In terms of the systemic stuff, so how do we do it? So taking a transdiagnostic approach is the first way of thinking that we talk about, and looking for those functional relationships. So formulating rather than diagnosing. So formulating, well, why? What is it that's driving the use? What are the kind of the internal external triggers? What are the kind of classical conditioning processes? What is it that's going on for the person which makes drug and alcohol use and self-harm behaviours sensible at the time? What makes it a sensible thing within the person's perspective for them to do? Now, Jill Leng was really helpful. She gave us a load of advice, and there's a nice guideline. Now, it's around serious mental illness and particularly psychosis, but she reckons that some people have used this to good effect to cause people to take on people suffering drug and alcohol use, because this nice guideline basically says you don't exclude. You can't exclude people from mental health services on basis of their drug and alcohol use. Now, we may need to gloss over that psychosis may be a small part, so paranoia is often a small part, but if you do want a psychiatric category, then personality disorder would tend to be the one that would be used, but we would sort of prefer to talk about complex trauma, which has sequelae which look like psychosis and look like things like emotion dysregulation and identity issues, which then might get diagnosed as personality disorder. So clarity about how the mental health and drug use are functionally linked. Now, this is something we've been trying to do in Portsmouth, and so to help our mental health colleagues to help the people that we want. And what we've needed to do is very much engage on an interpersonal level with the people. So go and sit in meetings and help the mental health services to understand those links, those functional links between the two, rather than just saying, well, it's a drug use and a mental health problem. And that then opens up a whole world of treatments, and particularly MDT treatments. We published a paper around engaging the inclusion health populations a while ago, and MDTs are essential, and they are essential in the effectiveness, it seems, of treating people with drug and alcohol use. And of course, you need to have pharmacotherapy available. You need to have the ongoing community support available and psychological support available. So MDTs are really, really important, and often they're difficult to arrange. We need the support to get over appointment systems, and so place and structure of the way in which the care is delivered tends to be to the convenience of the care system rather than the convenience of the people, and support services to work around the drug use. So scheduling according to patterns of use, withdrawal, etc. So, we know that alcohol and different drugs have, rather than this blanket, well, they've got to use because it won't be effective, we need to think in a much more nuanced way. So around alcohol, what we used to do is schedule the appointments early. So there would be, after a can to stop the rattles, then we'd do a bit of work, probably only 30 to 40 minutes work, before they needed to go and continue to drink. But in that time, we get a bit of a window where some of the psychological work can be useful. We need to think very carefully about it. Psychological work that relies on memory or on highly structured days tend to be less effective, but then nevertheless there are really good basic CBT systems which and methods of treatment which can be incredibly useful, and they're very concrete, and we've found them to be useful with people drinking. If it's cannabis, yes, it's entirely untenable. I've tried to treat people who are still using a lot of cannabis, and it's they're cognitively seriously knocked off. So that's about scheduling our appointments around the use and before. Maybe earlier when they haven't used so much, so they're not able to make use of the treatment that we're offering. Heroin's really interesting, of course. After the initial use and the gouging phase, people can be incredibly functional and be right on it. So that, the treatment is ineffective, we can get over through just nuanced scheduling and nuance of the work, and thinking very carefully about the kind of work that can be done. So we need to be thinking about the difference in the drug use. And of course, they're not all the same. And of course, drink is not the same kind of drug use. So we just need to be thinking carefully about the contingency around those. And of course, in the long term, what we need to be doing is enabling drug services to go to the people. But that's our long-term plan. And I know that some services are already doing this, and they're getting some great results. In terms of the individual, assessment of change is really, really important. Wherever I've fallen flat on my face, which is quite a lot, It's because I've assumed that people are ready to make behavioural change. Oh yeah, of course I'll do that. Of course I really want to stop. And that's actually moving people around that kind of cycle of change straight to behavioural change it just doesn't work. If people are pre-contemplative and really getting into these honest conversations about how pre-contemplative somebody might be, and getting away from them telling you what they think you want to hear, what will get you off their back, it's a key skill. It really is. And this is all about the engagement phase and establishing a good watching a relationship. So the watchful waiting stuff, but also we've been working quite a lot with values-based intervention discussions. So we start off, it's not about the drug use. It's about what people value, what people can see themselves doing, maybe starting to get into what people might be doing if they weren't using, or where their current use gets in the way of the things that they might value. So it really isn't, the initial discussions aren't about drugs at all. They're about what the person wants, keying into autonomy. So MI, motivation interviewing, is lovely with this language. It makes a really nice use of something called self-determination theory. So people are more likely to behave in particular ways if they have autonomy, they've decided to do it. They're doing it with people, sort of a sense of relatedness, that kind of warmth you get with doing stuff and sharing kind of common outcomes. And also there's a sense of success, that the tiniest little successes will breed more successes. So self-determination theory is really important here. And one of the key things to start with is autonomy. We spend so much time telling people, or people are told so many reasons why they shouldn't be using. And of course that doesn't work, because if they already know that, and these are just rehearsing what they already know. Support with appointments and travel, we've talked a little bit about, and this, and we get into sort of the ways of working. So being reliable and this relentless compassion is really important. We talk about this a lot, is that we need to be going back and back and back. These are kind of the foundations for engagement and change. It's not giving up straight away, and the kind of the continuing the relationship and waiting, sometimes nudging, and sometimes waiting for the person to start to say, actually, I need to start to kick this. This is a problem, and they need to be saying that. As soon as they've started to say that, we're into sort of a very different and very useful kind of conversation. There was a load of stuff around contingency management, and so paying people to stop. Generally, I think the literature is around, because that's an extrinsic way of working, it tends to be that, of course, people reduce or stop when the contingency is there, i.e. when the payment is there, or the other reward is there. But as soon as the reward stops, people tend to go back to it. It can provide a break. It can provide a break in habitual behaviours, but then you need further work in order to help the person see for themselves why they might want to be doing making the behavioural change. We need to. One of the things that DBT is really clear about is that we need to be. There's no point working with somebody if emotion regulation is the primary reason that they're using. There's no point working with somebody if that isn't being satisfied in some other way, if they haven't got another way of regulating emotions. So things like grounding techniques, some of the very basic kind of DBT stuff that doesn't necessarily need a psychologist to deliver, can be really useful in thinking about those things. And then, of course, there's all of the kind of the drug treatment stuff and the CBT stuff about seemingly relevant decisions, looking at single relapses as relapses, or lapses and relapses, and those kind of things. We know quite a bit about that. But helping people, the kind of the fundamental thing where we start taking this approach is helping people understand, build up and understand, what is the predisposing factors to people using, what are the triggers, and particularly what are the consequences. And DBT's got a really nice, simple way of helping people do that. They call it chain analysis, where you start to help people to understand, well, what's going on that day, what are the kind of the past vulnerabilities, what are the kind of triggers that have led up to the particular use. If it's kind of things like emotion regulation, if it's the around the kind of the social stuff. But then, so we have the use or the problem behavior. It could be a self-harm behavior, or drinking behavior, or drug behavior. And then, most importantly, what are the consequences of that? How does that reinforce the likelihood nothing's being learned here, so you'll keep going around in that cycle. Now, this has been this is a psychological approach, but you don't need to be a therapist to use this. It's real common sense stuff. So when we do some of our psychological informed environment training, we teach this, and it's been a bit mixed, but we've had quite a lot of feedback that this is a really useful thing that hostel workers and frontline workers can use in helping the person to understand that the drug use didn't come out of nowhere. There was a whole load of stuff that preceded it, and then helping people being mindful and being really honest about the environmental consequences of use and all the personal consequences. So these are the kind of things that we can help people anybody work with according to a psychological approach, and these are some of the tools we can use. To finish off, a little bit of data. Scott and I and some others have just finished writing a systematic review, meta-analysis on psychosocial interventions in homelessness. Just finishing off for submission. The general thing in terms of there's a load of stuff around mental health issues, but there's some evidence worthy of note that we found in the review that motivational interviewing, cognitive behavioural therapy, and dialectical therapy are implicated in treatment, so successfully implicated in treatment of drug and alcohol and mental health problems within the context of homelessness. So these psychosocial interventions can be effective. A little bit more mixed data that we've been gathering. We did a sort of a pilot RCT a few years ago, and just looking at the red one. So the audit is the alcohol measure. We used the DAST as a drug measure in this, and we didn't really get any effect with the DAST over time, so pre and post, but we did get a medium effect size with alcohol treatments. But then with some of the services we've been running in Basingstoke and Andover and Winchester and Portsmouth, if we sort of aggregate that data, we get some drug use effectiveness, but no alcohol effectiveness. So it's mixed, and we need to do a lot more work on what the kind of mechanisms are, what it is that we're doing which is enabling successful treatment in those areas. The numbers are fairly small, in the tens, 40 to 50, I think. So some of these things these results may be coloured by some outliers. We're also engaged in a lot of process research, so trying to understand what links the historical stuff and adverse childhood experiences with kind of drug and alcohol use currently. And we do a lot of mediation studies. So I have a lot of clinical psychology doctoral students who do this kind of research, and we've got some fairly good data on things like impulsivity and particularly emotion dysregulation. It does seem to be a key feature. So we need to be thinking about ways of working with emotion dysregulation, which will underpin the drug use, but also a bunch of other mental health problems, so common processes. Just some references here this is the NICE guideline, but also a policy document on advancing mental health equality, which can be quite useful in arguing for drug and alcohol use not to be excluded from mental health services. And then lastly, a couple of things that we find very helpful. Samuel Beckett's extremely helpful here in terms of ways of working. So this idea of failing better is really important, because we will. And the resilience that comes along with understanding that we're not going to get things right immediately. We've got very blunt tools. The only way we can sharpen these tools, whether they're pharmacological and psychological, is to keep trying and pay attention to our failures as well as our successes, and ensure that we fail better each time and we learn something from each time we fail. And lastly, another kind of foundation, I think, for successful use for us as clinicians and services, and it's a really tricky one, is being reliable, doing what we say. And this is nothing technical here. It's just about the things that will result in people engaging, more likely to engage in attending difficult appointments and other things, is when we do what we say and we're reliable. This was a colleague of mine took this photo. Somebody scrawled it in one of the massive encampments around Los Angeles in the woods. We think we've got problems, but they've got around, in the greater Los Angeles area, they've got well over 50,000 people. And in Los Angeles itself, about 38,000 people who are living on the streets, including Skid Row, which is a real place, about 10 blocks by 10 blocks. I went and met a colleague of mine and had a look at it, and it is as appalling as you might imagine. where they've got about 2,500 people living in this area of Skid Row, which has been given its own city limits. So we think we've got problems, but in the US it's way worse. Anyway, I shall stop there.
Thank you very much, Nick, for that. That was really interesting. I'm conscious that there was quite a bit of jargon and abbreviation, so I'm going to stop the recording